This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hello and welcome. This is Justin Abbatemarco with the Neurology podcast team and the Cleveland Clinic here with Jennifer Orthmann-Murphy to discuss a practical approach to genetic leukodystrophies. Jennifer is an assistant professor of neurology at the University of Pennsylvania and focuses on acquired and inherited myelin disorders. We've spent a lot of time helping to better understand and identify these genetic disorders because I think as testing has become more accessible, it's obvious that these disorders are not as uncommon as we once thought. And then recently, we've had these emerging therapies to offer patients, which have been incredible. Some recent highlights that you could look back on are interviews with Xavier Arignac, who joined us on October 6, 2022, where he discussed these common genetic CNS disorders that can masquerade as neuroinflammatory disorders. He joined us back on February 12, 2024, discussing CTLA-4 deficiency. And then Stacy just had a discussion with Aaron Baldwin this year around the disparities in genetic testing for neurological disorders. So with that, we're really excited to welcome Jennifer to have this practical discussion on this really fast-moving field. Hello and welcome.
Thank you so much for having me.
We've spent a lot of time on the podcast helping to better understand and identify these genetic disorders as testing becomes more accessible, and it becomes obvious that these disorders are not as uncommon as we initially thought, and we have these emerging therapies to offer patients. I think because of this topic is so complicated, we're going to break this down into a two-part series where we discuss some of the common approaches to genetic testing, and then we can talk about some particular examples around some diseases in our second part. When should we think about genetic testing for leukodystrophies? Are there certain signs in the clinic on MRI that should make us explore this category further?
I came into this actually as a neuroimmunology fellow, where there was just always a few patients at case conference that we could not get diagnosis on. We looked at all of the more common acquired causes. They had full involvement of their white matter, bilateral, confluent. They had progressive motor symptoms, maybe cognitive impairment. And maybe sometimes we were landing on this primary progressive MS as a diagnosis, but it's really nonspecific. And I always was bothered by that. At that point, as an adult neurologist, I really wanted to find out how do you do genetic workup on adults to be able to see if there were more frequent genetic causes than we were aware of. And so I was able to start a clinic about 6 years ago to do that. And essentially what we're going to talk about is my personal experience of navigating this as the technology is becoming more accessible and more affordable to do in the clinic, although not totally straightforward. But essentially, I think for people that have these symptoms of white matter findings, typically, or progressive motor symptoms, even if they have maybe a family history or not, but maybe are a relatively younger age, these are the red flags that show up. But for any of these cases, and we'll talk about some more red flags, you always have to do the standard workup first because you're more likely to identify an atypical presentation of these more common disorders like MS and NMO and MOG or systemic autoimmune disorders than you are, at least as far as we know, a genetic disorder. But for the many different disorders that can fall into this category, the key features that might push you in the direction are this early onset of cognitive impairment. And what do I mean by early? I'm not even totally sure yet, but at least less than 60, we'll say, and still an adult. That there's a rapid progression of symptoms, that in addition to a CNS involvement, you have peripheral involvement, that there's a retinopathy, not just an optic neuropathy, autonomic dysfunction, and additional signs on exam that are in the history that you wouldn't expect for something like MS: seizures, tremors, Parkinsonism, dystonia, myopathy, deafness, palatal myoclonus, and then severe migraines, psychiatric manifestations, or systemic involvement that have progressed over time. On imaging, there's not always a way to distinguish genetic versus acquired. And I wish that we could do more pattern recognition like they do for pediatric leukodystrophy, but I haven't figured that one out yet. But there are some features that some of these disorders have that should raise the possibility that something else is going on. For example, if there's calcifications on head CT, if there are also spinal cord abnormalities, you can have that with a genetic disorder. And I'll say actually for the spinal cord abnormalities, sometimes more atrophy rather than specific lesions. If there's enhancement, like in the brainstem with persistent enhancement, it doesn't go away on multiple surveillance MRIs, or diffusion restriction with persistent diffusion restriction that doesn't go away on surveillance MRIs. Those are red flags for your more common acquired disorders.
I think it's a really helpful construct and maybe a way that we can work through this interview. I love that personal story, though, of sitting in a neuroimmunology clinic being like, this patient does not fit one of our typical buckets. We're missing something, and we've got to pull that lever for genetic diseases to at least think about it, test for those. It's so important today.
In trying to figure out when you identify them or even what to tell people to send to my clinic, I had to start somewhere. And so I basically said, if people didn't fit into a diagnostic criteria for the basic workup that you would do for it, and they had bilateral confluent white matter involvement, send them my way and we'll see what we find. It turns out, though, that the disorders that you can diagnose are also diverse within these presentations, even for these red flags that I have pointed out. I think to build on how do you think about these disorders, I think about them in a few different ways. One is is it acquired versus inherited? And that the acquired is more common and will present heterogeneously. And to be honest, all of the genetic disorders will also present very heterogeneously, so it won't necessarily narrow it down. The terms of the disorders that can cause it are genetic leukoencephalopathy. So that means, this is the one I prefer because it doesn't assume what the actual cause is before you've done the genetic testing. It's just a term that means that there are white matter lesions and it's due to an inherited cause. And then we're going to figure out what it is. The term leukodystrophy actually has been defined by the Global Leukodystrophy Consortium in a 2015 paper as to refer to a primary defect in a non-neuronal cell. And then within leukodystrophies, there are the adult onset leukodystrophies, or there are the set of leukodystrophies that could have adult onset, and they also can have pediatric onset. Typically, the adult onset variants are less severe, but that's not actually always true. And then on imaging, the other way to split this up is based on myelin. So we think of myelin as the main component of white matter, which it is in the brain, and the pathogenesis of what's happening to the myelin can be determining what the cause is. And the disorders that affect formation of myelin or the hypomyelination, those are typically going to have a childhood onset. And the disorders that cause damage or breakdown of myelin, like you would see in something like MS, where you get demyelination, those are more likely to have an adult onset. The other types of disorders that can cause overlapping imaging and symptomatic features are also these complex or complicated hereditary spastic paraplegias. This is the subset of hundreds of genes that actually cause these long tract disorders. So you have findings associated with damage to the corticospinal tracts, basically starting with leg involvement with spasticity and decrease in strength. You can have sensory ataxia and involvement of bowel and bladder. But these complicated ones also have involvement of white matter in other regions of the brain, leading to additional symptoms. And I'll just mention, we just had the very talented resident that I worked with, a paper on SPG11 as showing the ear of the lynx sign that you can actually see and identify on MRI for these HSPs that you identify typically in adults because they're later onset.
Red flags in your mind when you're thinking about this in clinic, especially for our adult patients, this rapid progressive cognitive decline, motor decline, sensory involvement that again doesn't fit into one of our typical neuroimmunology buckets like we mentioned. This involvement of other systems. So if we have combined CNS, PNS, or you talked about some ophthalmological complications. And then we have some imaging helpful hints, though there's nothing absolute. I think that'll be one of the main themes for our talk, but calcifications, significant atrophy. I love that idea around persistent enhancement or restricted diffusion. So these give us some clues that not fitting into a typical bucket that may bring us down this line of these leukoencephalopathies or leukodystrophies. Is that a good summary?
That's an excellent summary. Brings up another point too, that especially for the genetic disorders, that you might not be able to get to the diagnosis immediately. And it requires a long-term relationship with the person coming to seek help and on their diagnostic odyssey, and getting these surveillance imaging and labs and testing to see how things are changing over time, because over time it might actually start to fall in one of those buckets. You won't know until you have multiple MRIs that it's persistent, for example, and that this is not the typical course and it hasn't responded to steroid treatment or something.
Yeah, time may be that other puzzle piece to help put it all together. It's so important. Could we explore that HSP category a little bit? I think that's a really confusing category. I think it's really expanded in phenotype, right? Classically taught.
Yeah.
The simple and complex delineation. But could you talk about what do we know about that class of disease? When should we suspect go for testing along those lines?
I've only really started to even feel comfortable answering that question as a first pass. because I've seen now a few patients. I'm going to take a step back and say, based on my graduate school experience, I don't think I would have believed at that time when I was studying an in vitro model of disease that these presentations could belong to the same cause. So here's what I mean by that. When, as a graduate student sitting in the lab trying to figure out how gap junctions, those are like basically holes that form between cells, form between astrocytes and oligodendrocytes. I have to throw in the glial cells because they're very important to me and we're all contributing to the disease here. They can present very severely in childhood, like Pelizaeus-Merzbacher disease. This is a spectrum of these hypomyelinating leukodystrophies. But once I had worked out those experiments to show what was wrong with those mutations at the time, we heard from Italian neurologists that they had met a family with HSP, where basically there were adults who had difficulty walking and white matter lesions and spasticity and, eventually needed to get into a wheelchair. These are stories that we hear a lot in the adult neurology clinic and get people worked up for MS, right? But when you have a brother and a sister and an aunt who all have the same thing, then you start to wonder what else is going on, right? And so it turned out they all had different defects in the same gene. And my thesis was working on that they had different effects on the function of that gene, the protein that came from that gene and the gap junctions, which was explained everything, which was all very cool for back when I was a PhD. That was way before I even saw patients and understood the implications of that. As a fellow, when I was interested in working on doing genetic testing, I went down to Craig Blackstone's clinic when he was at the NIH at the time to understand what does HSP look like, even in the simple form. Because when we see MS patients, it just depends where the lesion shows up, how symptoms evolve, and they typically are not so straightforward. And the people that I saw just have this very slow onset in adulthood, starting at the legs and moving the way up of a subtle change in gait, a tightness in their legs, and trouble going to the bathroom. And really, for the simple HSPs, it was limited to that. Most of those are due to various defects, as far as we can tell, in neuronal function. But there's a small subset of them that don't just affect neurons. Some of the genes are specific to oligodendrocytes and therefore myelin, and that's where it gets complicated. As we learn to identify all these genes and all of their functions within the CNS, we're probably going to find that they're not so simple, is all I will say. Unless there have been the case where I have seen people who really just had those symptoms limited to cortical tracts, and then I would think that maybe we should just stick with an HSP panel. But more often, I'm thinking maybe it's more complicated than that, and we should do broader based testing.
And maybe that's a perfect lead on to how we approach these genetic testing, because it's complicated, right? I think we can say we should explore genetic testing, but how we do it in the clinic when we're busy seeing many patients, how we think about and organize that. Because again, I think HSP is a perfect example of just this huge spectrum of phenotypes that can present in ages. So could you give us maybe a few clues on how you approach that in your clinic and how people can do that even when they don't have access to these dedicated genetic counselors and other research-based assays that I know you have?
This changes every few months, actually, what the right thing is to do. But my general principle is what will be the fewest number of tests for the least amount of money that will give us the answer. I think how I learned, at least, was to identify the distinct features of a disease, say like CADASIL, and you think of Notch3, and you send Notch3 testing. And in some cases, that's good enough. But actually now, I don't send single gene testing unless there is a known family history of a disorder, because it will actually be more expensive to send gene after gene. At minimum, for clinical testing, panels are typically affordable, or if you don't want to send additional testing, if that's negative, you can start with this broad-based next-generation sequencing of exome, which is about 2% of the genome, or whole genome sequencing, which should ultimately be the gold standard and is becoming increasingly affordable and accessible, but is not quite there yet. We can sometimes get it. And this is without any research testing. And I typically actually do clinical testing. And it ends up being a conversation also with the patient about how far they're willing to go to answer the question, how much they're willing to pay, and what we can get. So we don't actually always arrive at the same answer for every person. And I actually am very fortunate to work in a department with the neurogenetics division and many genetic counselors. And you said you spoke with Aaron Baldwin. I am very fortunate to work with Aaron. So we meet actually before every clinic. I have clinic 1 day a week. We meet ahead of time and we actually discuss what our strategy is going to be for every single person, and then discuss that with the patient once they show up to see what they would actually like to do. And so because we have the access to the genetic counselor, they are able to get the family history, counsel on what it means to get genetic testing. And here's the key thing. This can be done by anybody, but is really important part of the conversation is what it means to get genetic testing, what it means for you, what it means for the rest of your family, and what it means down the line financially. So you can't be discriminated against for health insurance, but you can be for life insurance and disability insurance. And so some people need to know that before we send the testing so that they can get it if they want to, for example. And so sometimes it's okay to have a little bit of delay while people get everything together that they want to before finding out what's actually going on. So that's one key thing. And then understanding what the implications are of diagnosis. But obviously, as people are being trained how to do this, and you can go to a specialty center like us, you can't see everybody yet, and not everybody knows and has access to that. It turns out that many of the genetic testing companies out there have, as part of their costs, you fill out the forms and they will do a benefits testing for you to see how much it will cost, the same strategy. What are you willing to pay for this testing? And they'll let you know before running it. And then they can actually provide genetic counseling virtually, both before and after the testing. So it's actually not out of the realm of a general neurologist to be able to get access to that. And sometimes even at your center, if you're at an academic center or if you're at a hospital, your hospital may have set up an association with one of the testing companies to send it there. So you can actually ask them and find out. And then I would say that the other thing that you could do if you weren't sure is to contact your local genetics department. It could be medical genetics to ask them who they most closely work with and get consistent results from. Because again, this changes frequently. What worked maybe 2 years ago may not be the same now. And I'll give you an example for that. There was a sponsored leukodystrophy panel, and it's no longer sponsored now. So there is some cost associated with it. And so that really does change your strategy about what is the right thing to do. The other thing on panels is that they change which genes are on them. And it's not always all the genes that you think should be included. So you have to pay close attention to that. So in the end, I tend to go with the more broad-based testing if we can, because we're not assuming we know what the cause is.
I absolutely loved your opening line there. It should be a mantra for all of neurology, right? The fewest tests with the least amount of money to find the answer, right? I don't know, it's elegantly put in a simple way, but it really does apply to this. And what I was hearing, some big takeaways there, it's definitely an individualized approach. I appreciate some of those real world examples with disability insurance and other factors, how it impacts family members having children. And so making sure that we're having those discussions ahead of time. And then broad-based testing. We've heard that in other podcasts is definitely the way to go. I don't know, is it an appropriate analogy? So you talked about this genetic testing, working with the companies. It almost sounds like what we do for our disease modifying therapies. You're partnering with them for copay assistance and other resources. And it sounds like we can do something similar with these genetic companies where we're relying on some of their resources for copay and some genetic counseling so that we can really utilize all the tools in our toolbox. Is that an okay analogy?
I think that's exactly right. I felt that was almost what I was saying. Actually, the same approach for our MS meds for DMT is that I can say that they're relatively higher efficacy, but there's adverse effects. So we have to talk about what's going to be the right match for you. And that's really how we go about the genetic testing at this point.
It's really helpful. Again, a practical, you guys have an incredible amount of resources in your clinic, but we've got to get access to all of our neurology patients to these kind of resources. Another thing that scares people that's challenging to interpret are these variants of uncertain significance, right? This testing comes back, you get that immediate MyChart message, and it's hard to think through and triage. Could you give us some points on how you think through them, how you talk about them with patients?
Yes, this is the bane of the report, but also has the potential for novel findings, right? And so there's several ways to approach this. The first is that we always talk about it as a potential outcome ahead of time, right? We can get negative result, meaning they don't tell us anything. We can get a positive result, meaning they give us a known or likely pathogenic variance, and this is the cause of disease, right? But more likely, we're going to get a variant of uncertain significance. And there's many reasons why that might be reported. So I'm actually going to take a step back and talk about what the reports represent, because I think this might be a bit of a misconception. So if you do broad-based testing or even panel testing, but we'll stick with broad-based testing, while you sequence everything, the report is actually subjective. you are more likely getting a report and interpretation of the variants just of the genes that they have thought could be associated with the phenotype. And they're basing their interpretation of the variants on what is available in the known databases, which are incomplete. We don't fully know what's normal quite yet. This is basically a subjective report. So embedded in all of these studies is that if you get a VUS or you get a negative test, it actually means it's negative for now, and we're going to check again later. For the exome and genome testing, there's a reanalysis embedded in the cost, and we do that in 1.5 to 2 years later because we may have learned about those variants. We may have found other family members that we could also send testing on to see if they have similar symptoms and that same variant, which would give us more information that maybe that variant is the cause, or somebody may have reported it in the literature. Another resource that you can use is something called Gene Matcher, where it's like variant dating, where you enter your variant and the associated phenotype to see if anybody else in the world has had a similar experience and that you can match up. And that has actually led to diagnoses. So this is a great resource to find rare phenotypes throughout the world. Or you look at this variant and you see generally in the reports, it will tell you what sort of disease it's typically associated with. You can get a report of a pathogenic variant, but if you read about the disorder, it says it's associated with a autosomal recessive disease. So that means that person is a carrier. Genetic counseling will be reassuring to them, but they might have to think about this in the future if they're family planning, right? But they don't have that disease, right? Unless you dive down deep and find out all the types of variants that could cause it if you needed a second variant, and whether the type of genetic testing that you did would account for those, like if they're intronic or expansions or something. So this is where it gets complicated. But if it's a disorder that is missense and you have one VUS, then off the table right now. And if you have any questions, you find an expert on that gene and ask them. That is always the correct thing to do. There's other ways to approach it. So then the other thing that you can do is do broader based testing if you haven't done it yet. And I guess the last thing I would say is that there's just so much more that we need to learn about this than we actually know right now. And so as many opportunities to participate in research and understanding of the variants is the way to go. And everybody who sees me gets offered participation in the Myelin Disorders Biorepository Project, which is run centrally out of CHOP, but is part of the Global Leukodystrophy Initiative. And actually, anyone in the US can fill out the CHOP Leukodystrophy Center REDCap survey to participate in research and be a part of that. You don't have to actually be seen in person to do that, although you could be either by them or the associated site if you want to be. And so it offers another way to collect research samples to collect those variants so that if someone becomes interested in that gene, they can say, oh, this one has been reported as a VUS. Let's test it in my new assay, for example.
It does sound like having that friendly geneticist in the background on speed dial to help analyze things, always helpful.
It's very challenging. I think it's unavoidably challenging. And in our notes, we just have to say that at this time, based on the available data, we don't think it represents disease. But you still could be wrong, right? If there is a resource for the disease associated with that gene, like on Gene Reviews, which is a great place to look when you do get a positive diagnosis or a VUS, you can always do the appropriate surveillance screening or whatever that's associated for that just in case. But just thinking that you should send to someone who is even an email, do you think that this could be pathogenic? A summary of the case is always welcome, I think, to anyone who's working on these.
But I thought your point at the top, and it's not something I would have thought about before this, is that it's a subjective report. And I think we know this for every other test that we do, MRI, EEG, it all has its limitations. I think sometimes when you get that genetic report, it feels like something that's written in stone, and these points on the reanalysis and thinking about how fast this field is moving. I think it's such a nice, simple way to put this all in perspective. And again, the same way that we do for other tests.
And actually, the one other thing I want to mention before I forget is this is hard for everybody in this field, the VUSs, and we often discuss with each other. And I'll just say that one of the opportunities to do this is something called White Matter Rounds. That's an international monthly case conference for adults with white matter disorders of unknown cause that's run by Roberto LaPiana out of McGill. There's a website that you can look that up. And actually, experts from all around the world join into these discussions. They're amazing.
So this will conclude our first part of a two-part series talking about this practical approach to genetic leukodystrophies. I think we really helped to set the stage to how we approach this really complicated group of disorders. In the second part of this episode, we'll talk about some particular examples, including HSP and X-linked adrenal leukodystrophy, how to think through and test for those diseases, along with some misconceptions. So please join us for that second episode.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes, or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.